Hello, everybody, and thank you for allowing me to join you. My name is Dr. David Benedek. I'm a retired United States Army colonel and psychiatrist, and now I am the professor and chair of the Department of Psychiatry at the Uniformed Services University. I'm glad to be with you today. Today I'm going to talk about fostering resilience, restoring to mental health soldiers after combat. And I'm going to talk about doing this in the setting both of returning to military duty or in an effort to reintegrate into civilian life. Before I begin, I should note that the ideas and attitudes and opinions that I'm going to talk about today are my own. They don't necessarily reflect those of the Uniformed Services University, the United States Department of Defense, or any branch or agency of the United States government. And I have no conflicts of interest to disclose. As an introduction, I'd like to remind you all that in the aftermath of traumatic exposure or traumatic experience or combat, service members, soldiers, just like other members of the population, can experience a range of psychological responses. For the majority, resilience or health will be the response. Others may experience distress reactions, such as sleep problems, a decreased sense of safety, physical symptoms, anger, or isolation. Still others may experience changes in their health risk behaviors, like increased alcohol use or tobacco use, abuse or misuse of prescription medications, family conflict or interpersonal conflict, and just a disrupted sense of work and life balance. And for a smaller subset, psychiatric disorders will occur. Those disorders certainly can include post-traumatic stress disorder, but may also include depression, anxiety, or complex grief or prolonged grief or mourning over lost comrades. I want to define a couple of terms as we go forward, as we start to work towards thinking about diagnosing and treating post-traumatic stress disorder. Remember that a combat or operational stress reaction is a transient mental, emotional, or physical distress reaction that can result from exposure to combat and combat-related conditions. An operational stress reaction may also result from violent or non-traumatic pressures like the loneliness or boredom or the physical discomfort of combat deployment. And those reactions can manifest in forms such as conflict within a unit, disciplinary problems, drug or alcohol misuse, or poor work performance. And then those are separate from psychiatric disorders. Remember, psychiatric disorders are clusters of symptoms which can overlap those of combat or operational stress reactions, but are distinguished by the severity of the symptoms, the degree of distress and dysfunction that they cause, and the duration of the symptoms. Another way of looking at this is to understand that a service member, a soldier, a sailor, a combatant, may demonstrate a continuum of symptoms across, beginning with sort of the green you see on your screen, which is healthy, normal, ready to engage in combat or other work-related functions. Yellow, reacting, which means having some symptoms, perhaps avoidance or anxiousness, worry, maybe some poor sleep, poor focus. Can progress to injured, and we see the types of injuries, being injured physically, being so fatigued or grief-stricken, or having such loss of function as to be decremented in one's work performance, to plain old ill, that is, having a psychiatric illness such as post-traumatic stress disorder or depression, as we've discussed before. It's important to understand that for soldiers after experiencing trauma who are in the yellow or orange columns of this continuum, those kind of symptoms, those that we might see in a combat or operational stress reaction, can be managed at the unit. They don't necessarily require evacuation or referral for definitive treatment. These, and I will talk a little bit about the management principles for these operational stress reactions before I get into the diagnosis and treatment of post-traumatic stress disorder. One more way of looking at this is to sort of understand a study that our group did with soldiers evacuated for physical injury from the war front to tertiary medical facility for treatment of physical injuries. And in the columns on the left are soldiers who ultimately developed symptoms of post-traumatic stress disorder. And on the column on the right are those soldiers who ultimately developed symptoms of depression. And the real point of this slide is that we looked at these soldiers at 1 month after evacuation, 4 months after evacuation, and 7 months after evacuation. And the points are that different soldiers declared themselves as having the illness at different time points, and that even across this 7 months from evacuation for physical injury, only a small percentage of soldiers developed full-blown post-traumatic stress disorder or depression. So again, many soldiers exposed to the horrors of war do not develop full-blown illness requiring treatment, and those that do may do so in different times after their return. So we have to think about how we treat soldiers who've been exposed to the traumas of war in terms of whether they're able to be returned to duty or whether they require definitive treatment or evacuation. So things that can be managed at the unit level are panic symptoms, fatigue or exhaustion, grief, sleep problems, just a lack of motivation or irritability. But illnesses that require more definitive treatment would include psychotic symptoms or manic symptoms, suicidal thoughts with intention or plan, or severe functional impairment to the point that a clinician or a commander determines this person can no longer do their mission. The frontline unit level concepts for managing combat operational stress as sort of defined by military practice in the US and doctrine are fairly simple, and that is treat proximal to the front lines, treat quickly, treat with an expectation that the service member should be able to go back to duty, and treat with simplicity, simple measures such as rest, good meals, a chance to shower, a chance perhaps to connect with some social supports, and then return to duty. These have been defined as PIES, proximity, immediacy, expectancy, or simplicity. Or the other acronym that we use is BICEPS, which stands for mostly the same things. The only additional idea is the notion of centrality, that this care should be located not necessarily in medical environment so that it stigmatizes or might stigmatize a soldier, nearby but separate from medical care. So again, for combat operational stress reactions, the type of symptoms that are transient and that do not require evacuation or definitive treatment, simple management principles, PIES or BICEPS can be utilized. Similar and overlapping with the concepts of PIES and BICEPS are the notions of psychological first aid. Psychological first aid is sort of a summary of the interventions that portend or can help create a better outcome in the aftermath of traumatic exposure for persons who do not necessarily meet criteria for depression or post-traumatic stress disorder. Those are any interventions that can facilitate calmness, can facilitate a feeling of hope or optimism, can facilitate a sense of self or collective efficacy that the service member or the unit can accomplish things themselves and don't need outside help, that those interventions that reestablish a sense of connection with others, that is a better communication, and then those measures which facilitate a sense of safety, that we are doing things to protect ourselves from danger. So psychological first aid for persons sort of integrated with the concept of PIES or BICEPS are management principles for treating service members who have transient reactions that don't amount to post-traumatic stress disorder or other psychiatric illnesses, and can be done at the sort of unit level, not at a hospital level. Again, first aid, psychological first aid includes attention to nutrition, encouraging good sleep, maintaining physical fitness, utilizing calming techniques, as I've mentioned before, and reestablishing social connection with professional peers, with colleagues, if possible with loved ones, although that may not be possible in a combat environment. Now, when we talk about soldiers who have returned from combat, who are either evacuated because of physical injury or because they have completed their tour of duty, there are some specific challenges. Essentially, some of the tools or skills that service members develop when they are fighting, specifically that heightened sense of vigilance, of being on guard and ready, that capacity to respond reflexively with using instincts, and using instincts in a violent way that is important to survival in combat. Those, along with sort of being able to maintain a sense of emotional numbness and withdrawal and separation from family and loved ones while fighting, and instead seeking only support from one's battle buddies, from one's brothers in arms, that's all very important in the combat environment. That's what keeps soldiers able to do their job. But those same traits, vigilance, reflexive violence, emotional numbness, and not using family and loved ones for support, those are not adaptive to civilian life. So that's the challenge. What worked during war does not work when one gets home. Our military has developed a training for soldiers to recognize this, and also for family members to recognize this. And I've put the reference here. This training is called Battle Mind, and it's a series of slides that sort of help soldiers understand what they used to function at war or in combat scenarios is not helpful when they get home. And it's also important for family members to understand this potential adjustment challenge, so that they understand why their loved ones, when they come back, only want to talk to their battle buddies, don't want to socialize with the family, may seem edgy or irritable, may seem jumpy, may react quickly without thinking. And there is a period of adjustment. And so for many, both family members and service members, reminding them that, hey, this is part of normal response or normal re-transition is sufficient, and again, doesn't require further psychiatric or medical intervention. Again, I'm talking about the idea that everybody exposed to trauma and war, not everybody exposed to trauma and war, develop post-traumatic stress disorder. And understanding and careful thought about the duration and intensity of symptoms is really what separates the challenging reintegration from those requiring medical and psychiatric intervention. I've showed this slide already, but I guess the point here is that as we think about service members that may require treatment for PTSD or depression, there isn't a magic time point. This study served to indicate that over the course of time, 1, 4, 7 months, illness such as PTSD may ultimately declare itself. And so just looking when someone first gets home is not good enough. We have to be vigilant over time for the emergence of symptoms. So let's talk a little bit about actually treating post-traumatic stress disorder. Our Department of Veterans Affairs and Department of Defense have, for a number of years, worked together to develop practice guidelines for the treatment of post-traumatic stress, to include post-traumatic stress disorder. And the most recent guideline was published in 2017. There is current work on an update, which will incorporate some more recent evidence regarding the types of treatments that I will discuss in a moment. And I've put the website where one can look for the DoD VA practice guidelines for a more detailed summary of the information that I'm going to present now. But first, let's talk about what the guideline says about treatment of PTSD. And I don't know that all of these figures will show up well on your screen when you look at this slide set. So I'm just going to point out the highlights. It basically, at the beginning, says, hey, if you are seeing a service member that reports symptoms, the first thing to do is a careful clinical diagnostic assessment. Remembering that sort of, hey, if a soldier says, I'm angry and I've been at war, that doesn't itself mean PTSD. Next, of course, is a safety assessment. Is the service member able to continue to work with you or others as an outpatient, or because of suicidal intentions and plans, because of profound psychotic symptoms, because of profound anxiety, does the person require hospitalization? Because that's important consideration before embarking on any type of outpatient intervention. Then the guidelines say, let's make sure we're talking about PTSD here. Let's make sure that diagnostic criteria are met. And then the guideline explains the potential and most effective, at least by evidence, supported psychotherapeutic interventions or pharmacologic interventions. So again, the practice guideline, I'm going to talk a little bit about the recommendations from the practice guideline at this point. Remembering that to establish the diagnosis of post-traumatic stress disorder, the symptoms need to have been present for at least 1 month. The symptoms must cause distress or impairment, and the symptoms cannot be due to another medical illness or substance use disorder. And so, again, the guidelines urge sort of care in making a diagnosis before embarking on treatment. What are the symptoms of PTSD that one needs to establish to make a diagnosis? Well, to meet the Diagnostic and Statistical Manual 5th edition criteria for PTSD, in addition to experiencing a trauma where life is threatened, or witnessing a trauma where life is threatened or serious bodily harm is a potential outcome, one has to experience at least one of the following symptoms: recurrent or intrusive distressing memories, recurrent or intrusive dreams, flashbacks, psychological distress on exposure to cues or reminders of the traumatic event, intense or prolonged physiologic reactivity on exposure to those cues. So one of those symptoms, at least one symptom of avoidance, avoiding memories, thoughts, or feelings associated with the traumatic experience, or avoiding reminders associated with the event, such as not wanting to be around people that were present, or people that remind one of those that were present during the trauma, or places where the trauma occurred, or situations. I was driving in my car when the bomb blew up, I don't want to drive, or even conversations. Anything, so avoiding reminders is one of those type of symptoms is also necessary. A soldier or a traumatically exposed person must also experience at least 2 of the following: inability to remember specific aspects of the traumatic experience, exaggerated negative beliefs about him or herself, their self, or about the world, persistent distorted cognitions about the causes and the consequences of trauma, persistent negative emotional states such as anger or depression, decreased interest or participation in previously pleasurable activities, feelings of detachment, or inability to experience positive emotions. So 2 of those symptoms. And then hyperarousal, either excessive irritability, self-destructive behavior, hypervigilance, exaggerated startle response, difficulty concentrating, or difficulty falling or staying asleep. 2 of those symptoms. And again, these clusters of symptoms must be present for more than a month, cause distress or impairment, and not be due to other medical illness or substance use disorders to be PTSD. Okay, so we establish a diagnosis of post-traumatic stress disorder. We have determined that the person we are working with is safe. That is, they are not acutely suicidal. They are not experiencing psychotic symptoms that would render them dangerous to themselves or others. And then what do the guidelines say about what kind of treatments to use? The guidelines are very explicit. They say individual, manualized, trauma-focused psychotherapy is preferred over other pharmacologic and non-pharmacologic interventions for the primary treatment of PTSD. That pharmacotherapy or non-trauma focused psychotherapy are sort of next if trauma focused psychotherapy is not deliverable, and that these trauma focused psychotherapies, if they can't be done in person, they can be done over a video teleconference or even in group formats. So again, individual, manualized, trauma-focused psychotherapy over other interventions. That because at least the studies of combat injured or combat exposed folks, persons, have demonstrated consistently that psychotherapy, there are larger effect sizes in the psychotherapeutic interventions than with the pharmacologic interventions. So what psychotherapy are we talking about when we say trauma-focused, manualized psychotherapy? We're talking about specifically prolonged exposure therapy, cognitive processing therapy, written exposure therapy, and there are some other types of psychotherapy for which the evidence is not as great. But all of the therapies that work for PTSD contain some element of re-experiencing or re-accessing the memory of the most traumatic event in a safe and different environment and reconsolidating that memory. Those are the basic principles of trauma-focused psychotherapy. Accessing the traumatic memory and reconsolidating that memory and giving it a new context. Again, the recommendations: individual, manualized, trauma-focused psychotherapies that have a primary component of exposure, and that's exposure to the traumatic memory, and or cognitive restructuring to include prolonged exposure, cognitive processing therapy, and then eye movement desensitization and reprocessing, and then other types of therapy with written or narrative exposure. And I'll go a little bit more into detail of those here in just a moment. Again, the major manualized trauma-focused psychotherapies are prolonged exposure therapy, cognitive processing therapy, and written exposure therapy. And I've illustrated here the manuals for each of those therapies, and I've done them in the way that I have to demonstrate that prolonged exposure therapy, at least as originally conceptualized, required 8 to 15 sessions over weekly sessions. Cognitive processing therapy was developed as a 12-week, 12-session psychotherapy, and then written exposure therapy has been most recently advanced as a 5-session psychotherapy. So all of these types of therapy are somewhat labor-intensive for the clinician and for the patient. Prolonged exposure therapy and cognitive processing therapy both require homework between sessions, so they're even more, if you will, labor-intensive for the patient than written exposure therapy, which is a 5-session manualized structured therapy, which involves the patient rewriting and then talking with the therapist about their most salient traumatic memory of traumatic experience. Okay. Some other thoughts briefly about the manualized treatments for PTSD. First of all, the manuals are available online. I put a site where you can go to access more information about these manualized psychotherapeutic treatments. That's the National Center for PTSD. And a little searching can find materials so that these protocols can be introduced. Again, the first two, prolonged exposure and cognitive processing therapy, require some homework between sessions that the patient will do. Written exposure therapy is essentially a therapy that is done in session with the patient. And then, even 5 weeks may be a long time. And there's beginning to be some research into, can these therapies be masked? Can more sessions per day, or certainly more sessions per week, be introduced in an intensive way to reduce the duration of required treatment? But that's, I would consider that at this time to be an area for further study. So not really, it's not yet in the practice guideline that masked therapies or abbreviated, more frequent sessions can be utilized. So what about medication treatment? Again, the guidelines say for combat-related post-traumatic stress disorder, trauma-focused psychotherapy is preferred. It may not be available. Our FDA has approved three medications for post-traumatic stress disorder, and there's good evidence for all of the SSRIs, the selective serotonin reuptake inhibitors, plus one SNRI, venlafaxine. And again, the SSRIs are paroxetine, fluoxetine, and sertraline, and the SNRI, for which there is reasonable evidence of efficacy, is venlafaxine. Again, may not be easy to read the dosing, but it's generally the standard dosing for those medications. For Prozac, for fluoxetine, it's 20 to 80 milligrams per day. For sertraline, it's 50 to 200 milligrams per day. For venlafaxine, it's 75 to, I think, 300 milligrams per day in divided doses, but the standard dosing instructions. There's less evidence for the efficacy of other antidepressants for PTSD, and there's some negative evidence for benzodiazepines. That is, a number of studies in U.S. veteran populations have suggested that the use of benzodiazepines for the treatment of PTSD may prolong the time to recovery and may interfere with the psychotherapeutic interventions as well. So whereas they may be used for acute anxiety, they should not be considered for therapy for post-traumatic stress disorder. So I think I'm at my summary point. What I really want to make sure that we realize is that, first and foremost, military combatants can experience a continuum of distress reactions after exposure to the horrors of war. War is horrible. Traumatic experience is horrible, but not all those that are involved develop PTSD. There is a continuum from resilience through the middle areas of combat operational stress reactions, or reacting or even injured, to ill, physically injured, to post-traumatic stress disorder. So that range includes psychiatric illness, but more often presents as subclinical distress: fear, anger, sadness, isolation, or transient reactions. So we as clinicians need to be careful to establish a diagnosis of PTSD before we embark on treatment of that. And we can realize that simple actions can mitigate the lesser stress reactions, i.e., those concepts that I articulated of biceps, of brevity, immediacy, proximity, simplicity, psychological first aid. Those measures, psychoeducation, those measures can really help those that are not suffering from post-traumatic stress disorder. Careful assessment and sort of recognition of intense or severe symptoms over a duration of more than a month sort of leads us into the realm of treating post-traumatic stress disorder. And for post-traumatic stress disorder, trauma-focused psychotherapy, and I outlined a number of these that are very specific and manualized, that is, scripted. The interventions on the part of the therapist are worked out and carefully adhered to, and in the sessions, and in the case of prolonged exposure and CPT with homework. And those are more effective than the medications. And when medications are the only alternative or more available or preferable to a patient, the SSRIs and the SNRIs in particular may prove helpful. Uh, just a couple other things. The reality in terms of pharmacotherapy for post-traumatic stress disorder, most studies are unfortunately are of mixed populations. That is, they include combat affected soldiers, but also civilians who've experienced trauma. Again, I've mentioned that the trauma psychotherapy effect sizes in those studies are greater than those for medication. There's no prohibition against mixing pharmacotherapy and psychotherapy. But they're not really great data to support augmenting using multiple medications. And really, even if medications are preferable or easier, ultimately it may prove that utilizing one of those evidence-based, trauma-focused, manualized psychotherapies is the way to go. So again, I hope this is helpful. I hope I've provided some access to some resources for more information about the specific psychotherapies and what is known about medication treatment for post-traumatic stress disorder. I can be reached at david.benedict@usuhs.edu, and happy to answer questions through email. And mostly, I want to thank you for your efforts and applaud you for your continued efforts to defend your country and to help your people. And it's really my fervent wish for peace in your region sooner rather than later, because these ripple effects of war will continue after the fighting ceases. So the sooner we stop that and we can get on to moving towards normalcy, the better. But again, thank you all, and continue the good work.